Good morning, everyone. My name is Darshan Mehta. I'm the Associate Director of Education for the Osher Center for Integrative Medicine at the Brigham and Women's Hospital and Medical Director at the Benson Henry Institute for Mind Body Medicine at MGH. Before I introduce my colleagues here, I just wanted to just alert everyone to just remind everyone that we hold these grand rounds on the first Tuesday of every month, and we alternate between our clinical case conference and then a research-focused grand rounds presentation. So our next talk will be on June 6th. It will be by Dr. Vitaly Napadau. We'll be talking about carpal tunnel syndrome neuroimaging study. So we look forward to seeing you there. And also as a reminder, if you haven't signed in, please do. You can get CME credits for today. And then the other is on Saturday, June 24th, our very own Peter Wayne will be conducting a one-day introductory workshop on Tai Chi for strong bones and balance, healthy hearts and sharp minds. The information is out on the table, but again, would encourage you to take a look at that as well. And then lastly, just want to remind that after our discussion here, we invite you to continue the discussion in our coffee hour, and it's just across the hall. We'll have a light breakfast and coffee available, and hopefully allow everyone to sort of continue the dialogue that we've started. So with that, I want to invite or introduce my colleague, Michelle Dossett. She's an assistant physician and a clinician researcher at the Benson Henry Institute for Mind Body Medicine at the Division of General Medicine at Mass General Hospital. And also Dr. Kevin Heist, who is the director of the Clinical Cardiac Electrophysiology Fellowship at Massachusetts General Hospital. And they'll be discussing a case on addressing symptom burden in patients with cardiac arrhythmias, the SMART, capital S, M-A-R-T approach in a 75-year-old woman with paroxysmal atrial fibrillation. So with that, Michelle.
Good morning. Can everyone hear me okay? Great. Thank you, Darshan, for the kind introduction and the invitation to speak to you today. These are just disclosures. I have funding from NIH to study the patient-clinician relationship, and Dr. Heist's disclosures are listed there. So today we'll be talking a little bit about the clinical course and symptoms of patients with paroxysmal atrial fibrillation, some of the psychosocial and physical effects of mind-body practice, and present a framework for resiliency building in chronic health conditions. So I'm going to talk just a little bit at the beginning here, presenting this patient's initial presentation to the Benson Henry Institute. Dr. Heist then will talk some more about her condition and atrial fibrillation in general. And then I'll share with you some of the rationale for why we think the intervention that we chose, the SMART program, would be particularly helpful in this patient population. Our patient, hopefully, will be here by then. She's driving up from the Cape, and share with us her experience in the program. And then Dr. Heist will come back up and share some perspectives on what happened with her from a cardiology perspective after the program. And then I'll just share with you some results from some pilot data that we have, and then open it up for Q&A. So our patient is what at the time was a 75-year-old woman who had a long history of paroxysmal atrial fibrillation that dated back to the early 1990s. And she had had an ablation procedure done in 2014, but still occasionally had intermittent episodes. And she had heard about our research study and was interested in enrolling. And this was her past medical history at the time. So she had a number of cardiac issues that were under reasonably good control at the time. History of asthma, GERD, some hypothyroidism, glaucoma, osteoarthritis, and the rest that you see there. And these were her medications. We pay a lot of attention to the social history when we see patients at the Mind Body Institute because this is often where stressors come up. And although I wasn't seeing her as a patient per se, just to get a sense from our research study perspective and to get to know her better, I wanted to have a sense of what was going on. She was married. This was her second marriage. She had 2 daughters from the first marriage and 2 stepsons from her second. She had a history of smoking but had quit many years ago, had a history of alcohol use but also had quit many years ago and was a regular attender of AA. She also has a women's group that she was part of that was a big source of support for her. And it was great that she had a lot of good social support at this time, but had a history of multiple stressors over her life course. And in the recent time when I had initially seen her, her brother had recently died, and she has 2 daughters who have chronic health issues. Come on in. And when patients participate in our clinical programs, we do some goal setting before the program starts. And I happened to find the goal setting sheet that we did together in this visit before she started the program. And this is my handwriting here, just sort of jotting down, summarizing what she had shared with me, getting a sense of what was bringing her into the program, what skills was she hoping to develop, and what would resiliency look like for her. In addition to teaching mind-body skills, the program also emphasizes a number of lifestyle, healthy lifestyle behaviors. And so I wanted to get a sense of what she was currently doing in terms of exercise, nutrition, and sleep. And the fact that I have established, sort of written on the side here, means that we thought she was doing a pretty good job with her diet. Her sleep was excellent. And really, her goal was to work on physical activity, which had been something she had done previously, but at the time was doing less of. There's a lot of data that social support, social connectedness are very helpful for resiliency to stress. And as I mentioned just a while ago, she had that already. She was also volunteering on a hospital board. And so we felt that was established. We also have all the patients who go through the program pick 3 symptoms that they're going to track that they feel are stress-related symptoms. And we were already going to track her AFib in the program, so we picked 3 other ones, and she picked abdominal pain, muscle tension, and back pain. When she saw me, she had just recently come back from a trip to Florida, and so she was feeling much more relaxed at that time, and so she was sort of estimating what these were like before her trip to Florida. And then we have patients rate stress, their ability to cope with stress, and the amount of distress that they're experiencing. And as you can see, she was in a reasonably good place at the time. And then we have folks track these as well as the symptoms as every week as they go through the program, along with tracking their mind-body practice. So I'm going to invite Dr. Heist now to come up and share some more.
Nice to see all of you, and nice to see our patient here in the audience to join us. She is 76 now, as we first met a few years ago, but a long history of atrial fibrillation dating back to the early 90s. And many people are treated with medical therapy, but she didn't tolerate those medicines well, I think in large part because she had a common condition with atrial fibrillation, which is what's called tachy-Brady syndrome. Tachy's fast and Brady's slow. So when she was in atrial fibrillation, her pulse would be very fast, but in normal rhythm or sinus rhythm, it would be quite slow, and anything we might give her to slow down the fast would make the slow too slow, and she just didn't tolerate it. There's also a stroke risk with atrial fibrillation, and she was anticoagulated, I think with a variety of agents, but ultimately one called rivaroxaban. and because of her symptoms of atrial fibrillation, underwent a catheter ablation procedure in October of 2014. So I think that for this group, there's probably a range of how much memory you have of atrial fibrillation or how much you may deal with it in day-to-day practice. So just hitting some basics, it's the most common arrhythmia requiring any sort of treatment. And in a arrhythmia practice like mine, probably half of people I see for atrial fibrillation. And the main thing that puts us at risk of it is getting older. And by about age 70, about 10% of people have AFib of some form or another, and by age 80, it's about 20% of the population. So it's actually extremely frequent. It's rarely life-threatening by itself, but it can cause a lot of symptoms, make people feel really miserable. Some people barely notice anything. Other people can't get out of bed and sort of everything in between, but people may have palpitations, shortness of breath, chest pain, fatigue, exercise intolerance, over a whole spectrum of severity. And for some of those patients with drug therapy, you can make the symptoms tolerable or even non-existent. For other people, despite drug therapy, they just don't feel right. Probably the biggest sort of real objective risk besides the symptoms is the risk of stroke, and that's typically treated with blood thinners, as it was here. So just to hit a little of the sort of data on treatment of atrial fibrillation, the big treatment strategies are either rhythm control, trying to keep someone out of AFib in normal rhythm, or rate control, meaning you live with the AFib when or if it occurs, but you give drugs to keep the heart from racing so fast. And for people that can tolerate their AFib, it's perfectly reasonable to leave them in AFib. This was the biggest of a series of studies done over a decade ago now. This was over 4,000 patients, and half were given rhythm control, drugs to try to keep them in normal rhythm, and half were given rate control, drugs that just slow the heart rate down in AFib, with the thought that there might be a benefit to drugs that keep people in normal rhythm or attempt to do so. There wasn't, and it was actually a big enough study to be powered for mortality, and there wasn't a benefit, and if anything, there was a statistical trend toward higher death rates with the antiarrhythmic drugs. So for many people that tolerate their AFib, we simply control their heart rate with heart rate slowing medicines and anticoagulate them. But some people don't tolerate their AFib, and they don't really care about the results of that study. If they don't feel right in AFib, you need to do something to try to keep them in a normal rhythm. The simplest thing you might do is electrically cardiovert someone, shock them into sinus rhythm. It usually works. It usually gets them into sinus rhythm, but it's no guarantee of staying there. So, after cardioversion, AFib recurs in most patients. And then we may give antiarrhythmic drugs as sort of per that first big study I showed you, but these drugs are not completely effective. This is probability of sinus rhythm out to a few years. After cardioversion with placebo, almost everyone, all but perhaps 10% of people have recurred within a few years. Sotalol is somewhat more effective and amiodarone more effective still, but even with the most effective drug, more than half of people are going to be back in AFib within a few years, and these drugs, amiodarone in particular, carry risks of toxicity. So all of the drugs have side effects and issues, and just haven't found a perfect drug for keeping people in normal rhythm. There are some drugs that work quite well for certain patients. I have a number of patients doing well on antiarrhythmic drugs, but many patients it doesn't work, either because it doesn't keep them in normal rhythm or they don't tolerate the drug. In this particular case, almost all of these drugs will slow down sinus rhythm. So if your sinus rate's already too slow, any drug you might give to try to keep someone in normal rhythm will make that slow even slower and make maybe mild symptoms from the slow sinus rate into severe symptoms. So drugs to maintain sinus rhythm or the drugs to control the heart rate weren't good options here. So then procedures were developed to try to keep someone in normal rhythm. The first procedures were actually surgical procedures, and this is the left and right atrium, just showing what was done. It was both a very long and morbid procedure, but a very effective procedure. And so basically these are surgical incisions. The left atrial appendage and right atrial appendage were cut off, and then cuts were made in the atrium in all these areas. These are the pulmonary veins. This is the superior vena cava, et cetera. So all of these cuts were made in the atria and sewed back together. And if you cut the atria apart and sew it back together, you'll create electrical block there. And it was called the maze procedure, with the idea that you sort of segment out the atria in a way that these electrical waves that would create AFib would hit areas of electrical block, and AFib wouldn't perpetuate. And this worked quite well. It probably worked better than anything that was done ever after, but it was just too big and too risky a procedure. There are still surgical procedures done, but they tend to be less aggressive than this initial surgery. But it gave the idea that a procedure could help to keep someone in normal rhythm if enough electrical block was created in the atria. And then about 20 years ago, catheter procedures came along. So instead of any invasive surgical procedure, catheters were put from veins in the leg up, crossing the atrial septum to the left atrium. And in the initial procedures, they looked at where when normal rhythm goes to AFib, there's fast electrical firing, fast electrical beats that stimulate the atria very quickly, put someone into AFib. So this group looked at where these come from, and these triggering beats, almost all of them occurred in what are called the pulmonary veins. This is an injection into a pulmonary vein, draining blood from the lung into the left atrium. And almost all of these, in a number of different patients, were coming from the pulmonary veins with just a few scattered foci elsewhere. So then targeted procedures using catheters to target the pulmonary veins came into vogue, initially trying to target the specific spot that was firing fast. It turned out to have some risk of the vein closing up, pulmonary vein stenosis, and it turned out not to be so effective. You might ablate what was firing one day, but another day something else fires. So procedures then were developed called pulmonary vein isolation. This is a view of the left atrium and the pulmonary veins here. And these red stars are just examples of where these fast beats may be coming from. But instead of trying to find all the different fast sources, a procedure to make electrically silent scar with a catheter all the way around the pulmonary veins, so that these veins become isolated electrically from the atria, and anything activating in any of these areas won't reach the atria to cause AFib. And this procedure turned out to be both safer and much more effective than the initial targeted procedures. Still perhaps not as effective as the large surgical procedure, but a lot easier to get a patient through with a lot less risk. In some cases, additional ablation is done. These are images from a real procedure with a catheter with the multiple colors that maps out the atrial tissue, and these red dots were all ablation lesions around the pulmonary veins here and isolating this area of the left atrium as well. So sometimes targeting additional tissue as well to try to get better effectiveness. And these procedures are more effective than drugs, but they don't work for everyone. This is a study taking people who had failed, so to speak, one antiarrhythmic drug. One antiarrhythmic drug didn't control their AFib or wasn't tolerated, to either give them a different antiarrhythmic drug or catheter ablation. And so this is freedom from arrhythmia by a few different definitions with the catheter procedure and with the antiarrhythmic drug. So of course it's highly significant and a really big difference, meaning mostly that the second antiarrhythmic drug was extremely ineffective. And the catheter procedure was reasonably effective, but not perfectly effective. And you can see about 30% of people have had recurrent AFib within a year of a catheter procedure. The second issue we deal with AFib, other than trying to control the AFib, control the symptoms, is the risk of stroke. When the atria is fibrillating and not contracting, blood can stagnate, clots can form, and worst thing that can happen really to an AFib patient is a clot leaving the heart causing a stroke. So for all comers with AFib, stroke rate untreated is about 5% a year. AFib increases someone's risk of stroke by about 5-fold. You take the same person with or without AFib. With AFib, they have about a 5-fold higher risk of stroke. About 15% of all strokes are caused by AFib. That risk increases with age, and it doesn't matter if someone feels their AFib or not. Unfortunately, for some people, the first presentation of their AFib is a stroke. They had AFib, they didn't feel it, then they present when they have a stroke. And there's something called the CHAD score, now modified to the CHADS-VAS score, trying to assess someone's risk of stroke with things like congestive heart failure, high blood pressure, increased age, diabetes, previous stroke, and the more points you have along the scale, the higher the yearly stroke risk goes. and the treatment is blood thinners. The traditional drug was warfarin, and in a variety of studies was much better than placebo, cut the risk of stroke by about 2/3. More recently, some of you may have heard of the newer anticoagulants, 4 different drugs in different studies: dabigatran, rivaroxaban, apixaban, and edoxaban, all shown to be more effective than warfarin, as effective or more effective, and as safe or safer than warfarin in terms of bleeding. So many patients, including our patient here, were not on warfarin. They were on one of these newer blood thinners that's either more effective and or safer. So we'll transition back to the program.
Thank you. So you've heard some background now, and the question is, why would we think about the SMART program in this case? And I'm going to actually just take a step back and share with you a little bit about how stress affects the heart. This is from a review for patients with heart failure, but I like the cartoon, and the physiology is very similar. So we know that stress has effects on the autonomic nervous system, increasing sympathetic nervous system activity, decreasing parasympathetic activity through the vagus nerve, and also increasing inflammatory cytokines. And this can lead either to direct damage to the heart muscle itself, to the vasculature, the blood vessels in the heart and the rest of the body, which can cause a heart attack. And this autonomic imbalance can lead to arrhythmias. In this case, in the example they're showing in heart failure, ventricular arrhythmias that in some cases can cause sudden cardiac death, but it can contribute to atrial arrhythmias as well. We know that about 1/3 of patients with AFib have depression and or anxiety, and that for folks with paroxysmal or intermittent AFib, their quality of life is as impaired as patients with significant structural heart disease, patients who've had a heart attack or heart failure. There's data from large epidemiologic studies, such as the Framingham Heart Study, that show that chronic stress is associated with the development of AFib. And another prospective study that shows that acute stress and negative emotions can increase the likelihood of an acute AFib episode. And this is data from that latter study. So they took 95 patients with paroxysmal AFib and followed them for a year. And at the end of each day, they had them write in a diary sort of the predominant emotion for the day. And if they were having symptoms, they had a monitor that would sort of capture what rhythm their heart was in at that time, and they would record what emotion they had been experiencing in the prior 30 minutes. And in this table here, you're seeing the list of emotions that some of the emotions they asked about. The top line is the unadjusted odds ratio, and the bottom is the adjusted odds ratio from a multivariable model, where they adjusted for age, gender, whether they were using a beta blocker, one of these medications to sort of slow the heart rate down, time of day, day of the week, and season. And what you can see here is that and 1 means that it's equivocal, no difference. Anything less than 1 is an improvement, so that happiness actually decreased the likelihood of an AF episode by about 85%, whereas sadness, anger, stress, impatience, and anxiety increased the likelihood by 2 to 5-fold. Hunger had no difference. There is a lot of data on meditation and its effects on the heart. Much of the early work was done by the Transcendental Meditation community, but other data in other traditions as well. We know that it reduces blood pressure, it improves heart rate variability. There is data that in patients with established coronary artery disease that it reduces subsequent mortality. And in patients with heart failure, that it decreases the levels of norepinephrine, one of these stress hormones, improves quality of life, mood, and functional capacity. And very recently, there was a study of yoga for patients with paroxysmal atrial fibrillation. They took 49 people. They just had them fill out surveys for 3 months, getting a baseline of what was going on, and then put them through a 3-month yoga intervention, and again had them complete surveys. The intervention was a 60-minute Iyengar yoga class twice a week with home practice. Each class consisted of about 10 minutes of pranayama or breathing techniques, 10 minutes of warm-up exercises, 30 minutes of asana or posture practice, and then another 10 minutes of relaxation exercises. They don't go into detail in the paper what those relaxation exercises were, if it was meditation or something else, but that's what they said. And this is the results from that study. The red is pre-yoga intervention, and the green is afterward. And you can see here there's a significant reduction in terms of the number of symptomatic AFib episodes participants had, the number of symptomatic non-AF episodes, so oftentimes people will have palpitations or symptoms and not be in AF, and also reduction in asymptomatic AF episodes as measured by a Holter monitor. And so at the Benson Henry Institute, we have this stress management and resiliency training program that's been developed over the course of about 4 decades of research and clinical practice. And we offer it for patients who come to the Institute. We began thinking that this might be a really helpful intervention potentially for patients with AFib, paroxysmal AFib. And so I just want to share with you a little bit about the framework for resiliency that constitutes the program. The first main component is teaching patients how to elicit the relaxation response. So when we're in our stress response, the hypothalamic pituitary adrenal axis gets activated along with the sympathetic nervous system. There's increase in the stress hormones, cortisol, norepinephrine, epinephrine, and these downstream physiologic changes that take place. And when Dr. Benson first started doing this research 45 plus years ago, he noticed that when patients started to meditate, their physiology went in the reverse direction. The sympathetic nervous system activity went down, and all of these downstream changes reversed. So he coined this term relaxation response, not to mean totally limp and not present, but that this was a physiologic state that was opposite of the stress response. And so we teach people how to elicit this state through a variety of different meditation and other mind-body practices. So different meditation techniques, because we find different people may find different tools more helpful. A number of mini relaxations that people can weave throughout their day. There's some yoga, and we include mindfulness as well. The second main component comes from sort of traditional stress management techniques. We all, because the stress response is a habituated canonical response, we all have certain ways that each of us responds when we're stressed, both physically, cognitively, emotionally, relationally, and behaviorally. And if we can learn to identify what our own individual stress response is, then we have the opportunity to begin to use techniques proactively before the horse gets out of the barn, so to speak. Unfortunately, many people out there are like this guy, right? And they're in a full-blown stress response, and then it's a little bit harder to work with. Or they're not even aware. And as I like to say, awareness is really the first step, because then you can do something about it. And then the third main component of the program is a whole host of adaptive strategies, and I'm going to go into these in more depth in the next slide. But really the combination of these techniques helps to result in personal growth and decreasing the stress response and ultimately the building of this construct of resiliency. So these adaptive strategies include social support, healthy lifestyle behaviors. There's a lot of data on each of these things as being helpful for decreasing stress, increasing resilience to stress. We don't have time this morning, unfortunately, to go into each of these. We also teach cognitive reappraisal and coping skills borrowed from cognitive behavioral therapy and acceptance commitment therapy. And we have worksheets and logs and a bunch of tools that participants complete as they go through the program and build those skills. And we also borrow from positive psychology and focus a lot on positive perspective building. And we do that in a number of different ways, but 4 areas in particular that we focus on are the development of appreciation, humor, acceptance, and empathy. So I'd like to invite Margaret up now to come and share some of her perspectives on what her experience was like going through the program. And thanks so much for coming and braving the traffic.
Good morning. If I don't pass out down here, or if I do pass out, I figured this is the safest place to do it. I've got a bunch of doctors to rescue me. I volunteered when Dr. Dossett asked if I would come and speak. I was absolutely delighted to do so, even though this is one of the most painful things in the world that I can do, because this program was so remarkable, and the AFib that I suffered was the kind that Dr. Heist. See, that's my stressor. Names will disappear on me. Dr. Heist followed me for many years. I had the kind of AFib that always felt like the movie of a crocodile in the stream when it grabbed the animal that was on the side of the water and turned it around. My heart would just, it was a very violent reaction. My heart would feel very like it was exploding. And I really couldn't do anything. It was panic producing. It was uncomfortable. I spent many, many times going to emergency rooms where they would interfere with the AFib. And when I heard of this program, the SMART program, and I was asked if I would participate in this study, I said absolutely, because I'm 76, and along the way I've learned an awful lot about what the mind can do and how learning to pay attention and doing some of these practices might help me. And I would have done anything to try and improve the AFib. In Dr. Dossett's introduction to the group that met together and gathered around the table, one of the things she stressed, which I want to stress with all of you, it was one of the most important things to me, was she said we couldn't do anything wrong, that whatever we did, it was fine. And she explained that we would be paying attention to our thoughts and try and focus on a particular subject, and if we digressed from the subject, that's normal in the mind, and bring it back. We would just go back to the subject again. So one of the things that I needed, and I found that almost all of the other participants needed, was the leeway to make mistakes. I think that the pressure that we have in life to do things perfectly makes it very difficult. Some of the practices that we did, and Dr. Dossett I had asked her what might be helpful to all of you. She said, perhaps I might explain some of the things that benefited me from the program. And one of the major benefits that I came away with was a much more positive voice in my head, where if I made a mistake, I tended to scold myself, oh, you dummy, why in the world did you do that? But in the program, I would say, oh, goodness, my mind is drifting. I've got to go back, and I would refocus on what I was doing. And we had practices in which we would change the terms in which we thought and write down how could we reword this in a much more positive way, and we would reword it in our thoughts. So this gave me a way was part of what gave me a way to stay calm and stay focused. I tended to get less caught up in the minutia and was better able to stay on the point that we were working on at in every one of these different practices. As she mentioned, yoga was one of the practices. I had endeavored to go get into a regular yoga class, and when I did go to the yoga classes, I felt that they were very beneficial. I would go through in my head some of the things that I learned in the SMART program and listen to the yoga teacher, and ultimately by the end of the yoga class I was asleep. So along the way, because I am quite a distance from Boston, it was a horrendous drive up here this morning, which is why we were late. I had a friend who lived in Waltham. She was my access to the yoga, and instead of driving up from the Cape and then driving back from the Cape, I would go over there and spend the night with her in her guest room and then go to a yoga class with her. And one of the experiences that I had on one of the visits was I went to bed and fell asleep. In the middle of the night, 76 years old, you get up fairly frequently to use the bathroom. I got up to use the bathroom and I went into AFib. And my reaction was, oh my God, I'm in AFib, what am I going to do? I'm in her basement guest room, I've been to these classes, and I went into my initial immediate panic. AFib, I've got to go to an emergency room. But I had been to my class, and we had done diaphragmatic breathing. And I had found the diaphragmatic breathing very helpful in class, and I had practiced it at home on a fairly regular basis. So I said, well, I'm not going to disturb my friend. Let me see what happens. And I can tell you that that was an overwhelming thought for me to not panic. And I lay down again, I put my hand on my belly and lay on the bed and would expand the belly and gently exhale my breath. And the next thing I realized, I was asleep. And I woke up again, same night, later on in the night, again to go to the bathroom, and the same thing happened. So I got back in bed and said, oh my God, this is absolutely amazing. It worked before, I'm going to try it again. And I had the same response the second time. I also have a sister. Oh, I should complete that by saying I woke up in the morning, I was not in AFib, I was absolutely fine, and I was energetic. This impressed me so much that I felt I had to share this with anybody that I knew who had AFib. And so I called a sister-in-law that I have in Cincinnati who suffers from severe AFib, the same kind as I do, the violent reaction where she's flattened and in bed. And I said, Judy, my God, I've had the most amazing experience in the world. Told her what my experience was, explained to the best of my ability diaphragmatic breathing. And she said, next time I go into AFib, I'll try it. So it wasn't very many days later before I got a phone call that said, oh my God, Margaret, you won't believe what happened. I went into AFib. She had the same pattern that I had had of always having to end up in an emergency room and be either converted or with medicine or electronically. She said, I got myself out of AFib. So I shared this with Dr. Dossett because I thought this was the most amazing thing that ever happened. And I share it with you because I just think it's so important to give feedback to doctors of how things work, because that's also how you learn. Not every one of you, and I don't know if any of you suffer from AFib, but I can tell you it was a gift from God. In terms of the overall program, and flag me if I'm going on too long, I find I'm far less frustrated as a consequence of this program. I'm able to spend more time focused on me instead of focused on this, that, or who needs what, and just taking care of things. My pattern in life was really never to have me first, and I can't say that I have me first now, but I have slots for me. And I recognize when I start to get overwhelmed, I've got my husband here, he would confirm that I'm now able to say, time out, I'm getting overwhelmed. I do use these practices. I use the diaphragmatic breathing. We were given discs that we could listen to that where we could focus our attention and relax the body. I no longer have the back pain. I no longer have the stomach pain. I have the arthritic pain, but I'm 76 years old, so I've earned that. I should give you one I'll try and make it brief, recent example. I was in Paris with a whole group of my family, and we were in a nasty taxi accident. And my immediate response as I saw this accident starting to occur, I was in a very relaxed state, enjoying myself. I'm witnessing an accident that's about to happen, and all of a sudden out of my mouth, after 60 years of not speaking French, I fluently told the driver, watch out, and he hit the brake, and in fact I argued with him afterwards about whose fault it was in French, and I haven't used French in forever. And we had injuries in the accident, and yet my emotional response was one of gratitude, because the accidents were minimal. I had seen it coming. I'd been able to warn the others, and instead of panic, we all ended up calmed by this. In fact, everybody in the car returned to a state of calm. So I don't know that I have explained what we did. I sat down for hours yesterday to look at my book, and I wrote a long talk that I was going to give you, and I tried to deliver it to myself, and I failed. So I decided today I would just come and let you know from my heart how I felt about this practice. It works. It was remarkable. And however Dr. Dossett and Dr. Heist deliver the information, let me just tell you, it's far better than you'd ever believe. So thank you.
So just a little follow-up. As you've heard, the ablation was mostly successful, but not 100% successful, and there were some episodes of AFib afterwards. She remains on anticoagulation to prevent a stroke, which would be the really disabling thing that we don't want to have happen. Despite not being on any medicines to slow the heart, the sinus bradycardia progressed, got slower and slower, I think finally with a heart rate of 38 beats a minute, looking at my old notes in the office when we finally said, probably time for a permanent pacemaker, which doesn't keep AFib away but keeps the heart rate up, and I think we felt a lot better after the pacemaker went in. I'd just say from sort of a big picture perspective that what you're hearing is a very real phenomena of sort of a patient-tailored approach to dealing with their AFib, that part of it is the medicine and part of it is the procedures and ablation and pacemaker in some cases, but part of it's how an individual person deals with this. And not everything works for every person. Now, There are some people that when they get very, very stressed, they go into AFib, and if you can avoid that stress, they may have a lot less AFib. And it's easy for me to say, well, get the stress out of your life. I haven't figured out how to do it for myself, let alone my patients. So I think a program where someone can learn to do that is very helpful. And there are objective data like what you were shown with the yoga study of less objective, quantitated AFib, but there's also managing, being able to deal with the AFib. AFib doesn't mean someone has to run to the emergency room, and there are lots of people who have been in AFib continuously for 30 years, and they haven't spent 30 years in the ER. They're doing their activity. So if someone has a way to cope and to deal with their AFib, they may have less of it to start with, but on top of it, they can manage it, and they can deal with it at home, and they don't have to rush in, and it's not such a big deal. And I think you've seen some evidence for that.
So just to wrap up, I just thought I'd share some of the preliminary results from this study. We had 8 individuals participate in this group, and we saw a significant decrease in anxiety and a trend toward improvement in AFib symptoms, perceived stress and depression, and mindfulness. And it was really a treat for me as a clinician to run this group and just see the changes that were taking place over time. And I remember when Margaret came up to me in the beginning of one of our classes and said, "Your hypothesis is right." I was like, "What?" And then she shared the story that she had shared about the diaphragmatic breathing. So, and we asked for some qualitative feedback as well. And I just share a few of these quotes. "I don't think I ever knew what it was to be present, and I'm finding that I have discovered it here, and it's causing a tremendous appreciation for every moment that I'm in life. One of the significant parts was how to walk myself through the negative and get to the bottom of the negative thought and transpose it into positive. I had a lot of negatives, and I was chronically perseverating about one thing or another, and I'm able to not just cover them up, but discharge them and move on, and I'm laughing a lot, mostly at myself. I'm working very hard for daily meditation practice, which I find very calming and stress reducing. I find that the belly breathing exercise, the intentional breathing, is an enormous help." So with that, I'd like to invite our speakers and guests up to the front here, and we'll open it up for questions. Thank you.
First, I just wanted to thank. Well, first, thank you, Margaret, for really coming here. The wisdom that you provide really helps to put all of what we do, certainly on the clinician side as well as on the research side, in context of what it really means from the experiential perspective. So thank you for your grace and courage for willing to share your story with us. And thank you, Michelle and Kevin, for a fantastic presentation of just thinking how do we begin to think about atrial fibrillation comprehensively in a very complex medical system that we all live in, so with many options, and how do we really craft the right approach, and what do we do to achieve that? So we have a few minutes for questions. And wanted to open it up for some discussion as well. So I think we have a question in the back.
Were there any patients in the study that were asymptomatic?
As I recall, everyone noticed symptoms when they were in their arrhythmia. That doesn't mean that they noticed symptoms every time they were in their arrhythmia, but they definitely had symptoms.
What would you recommend for someone who is asymptomatic with the SMART program? Is that something?
Well, I guess I would sort of take it back to how much stress is this person experiencing in their life. And we have a lot of data in other patient populations as well that it improves stress. So I think it has the potential to improve quality of life in other ways.
Just as a follow-up, Dr. Heist, I thought maybe you might, as you direct EP fellows, and so just kind of curious, in the training of electrophysiologists, how does this concept enter as part of how they're taught to treat patients?
I think that the cardiac electrophysiology fellowship is probably an unfortunately procedure-oriented fellowship, and I think that what we are trying to is this not working? Is this working, or shall I maybe? This better?
Mm-hmm.
So cardiac EP fellowships are very procedural-oriented fellowships, and we actually try to push back on that. I think some of the fellows would be most happy if patients were wheeled into the room for the procedure, they did the procedure and wheeled out, and that was really all that was the fellowship. But that's not all there is to learn about dealing with arrhythmias in people that have arrhythmias. So we see patients in the office with them. We talk about managing them on sort of all levels, and I think the behavioral strategies and coping strategies are important. And I think the fact that some data, like you saw here, and there was a series of studies from Australia called CardioFit, that people with AFib who, besides the usual treatments of drugs or ablation, had weight loss, diet, exercise, and sleep apnea treatment, if they had that, who had those strategies on top of the usual, did a lot better. And there were several studies. They were published in pretty high-profile journals, and it made people see this isn't squishy stuff to push to the side. This is real, and this is part of treating people with AFib, and this leads to better outcomes. So we're trying to get that to be more prominent in our fellowship, that it's not just a procedure or a prescription of a drug. It's treating a person, and there are different aspects to that.
Another question. Yeah.
I'm not from medical background, but I have an AFib, and I have a doctor at Beth Israel who said to me, Mass General has a program, so before we start you on any radical medications, why don't you go through this program and see how it will help you?
And was it this program that's being described today?
Well, a friend of mine works for Mass General, and she told me about this lecture, so that's why I'm here. I think it's open to the public, right? So I represent the public, not the medical community.
Yes.
And I wanted to know if it's ongoing program and how to sign up for it.
So we've applied for some more funding to run more groups like this as part of a research study. But we also have clinical programs, and patients just come in and take the program, usually after seeing a physician at the Institute, either myself or Dr. Mehta, for an initial consultation. But come up and I'll give you my card, and we can figure out something for you.
Okay, thank you.
You're welcome.
Behind. Yep.
It seems like the whole program is very much directed toward what I'm going to call stress-related AFib. And I have a number of questions about that. So first of all, is that sort of a recognized categorization, sort of stress-related versus other? And so how did you screen people? Were there eligibility criteria for the study that sort of required them in some way to have what I'm calling stress-related AFib? And so I have another couple of related questions. So when you showed the results at the end with the pre and post, so I'm not familiar with those scales, but I'm just wondering if someone who would look at like the depression score and say, oh yeah, that's in the sort of not normal category and so on. And finally, do you have any reason to believe or evidence that this program would do anything for people who have AFib, but it's not stress related, whatever that means?
So I'll tackle the eligibility criteria first. We took anyone who had paroxysmal atrial fibrillation. We didn't require them to have stress, but I can say pretty much everyone who came into the study, and then maybe selection bias, had stress of some degree or another. Do you want to tackle the stress-related versus other?
I think that there are sort of subcategories of AFib in terms of what triggers someone's AFib, and there do seem to be people that stress is a bigger trigger for their AFib than others. There's probably a smaller variant of vagal AFib. When the vagus nerve is more active, there are people that literally every time they go to sleep at night, they go into AFib, and when they wake up, they pop out of it. I wonder if these strategies might be more effective for the sort of more stress-oriented AFib than not. There aren't hard and fast criteria to say this is stress AFib and this is not. It's sort of more in the eye of the beholder. And if it seems like at stressful times this person has more AFib, we may label it that way, but it's considered a pretty subjective label.
And I'm actually thinking there's at least one person I can think of in the study who did not think he had that much stress in his life overall. He thought, I have a pretty good life. Everything's, sort of moving along fine. And over the course of learning these skills, he found value in them, and he realized he actually did have some stressors that maybe might be contributing in some way.
But did it improve his AFib? Did it reduce his AFib symptoms or occurrences of AFib?
Many of the people who were in the study had very rare episodes of AFib, and so we weren't, although that was sort of a goal, we weren't following them long enough to really be able to tell that. And so that's why we were using some of these other measures of health as well.
May I ask you, Margaret, did before the program, did you feel like stress was a big contributor to your AFib, and did going through the program change your viewpoint on that?
I have to give that a moment's thought. I think that stress sometimes caused my AFib. It was not uncommon for me to wake up in the middle of the night in AFib. And when I appeared to be restfully sleeping, just out of the clear blue, I would go into AFib. So it was what would trip me into AFib was unpredictable. Clearly, the program improved stress. And as you know, at this point, because I have the pacemaker, I really can't tell you whether it would stop the AFib at this point. But at this point, of course, I use the tools for other reasons. And I find that just the quality of my life is so much better. And I'm not complaining about what the quality of my life was before, because the quality was good before. It's just so much better.
And the pacemaker doesn't keep AFib away. The pacemaker just keeps your pulse from going slow. At times it would go slow. So to whatever degree you're not having AFib is some combination of the medical procedures that were done plus the things that you've done through the program, that give you not zero AFib, but very, very little.
We'll see now. Whatever is going on, I do not have the violent consequence that I used to have before at all.
We'll get one final thought before we...
As a spouse of someone who has this, I'd just like to make a comment. I saw Margaret when she went into AFib, because we didn't have all the knowledge that we have now, the stress would be increased, and then that would debilitate her, and it would create a longer period of that AFib. So that once she got into this program and could handle whatever it was, I noticed that it wasn't as critical or as debilitating as it was before. So because she would really, lose days because of the AFib.
Okay. So again, really round of applause for our presenters here. Thank you for a fantastic, comprehensive presentation. Just to remind you again, we invite you to join us again next month on the first Tuesday as a presentation by Dr. Vitaly Napadau, and then again there's also a Tai Chi workshop. And not to provoke any AFib, but we do invite you to join us to come to coffee hour right across the hall, and please join us and continue this discussion. Again, the idea is really to promote and stimulate really cross-disciplinary dialogue, really to sort of build our framework of how we begin to think about chronic medical conditions and really novel and innovative ways of treatment, comprehensive treatment. Not to discount all the technology and medication has to offer, but in addition to add to it. So with that, we invite you to join us. Thank you again.